few days back, I had put up this question for this new thing that I'm starting, which is Public Health Policy Lab. I'd given a case and it focused on there were rapidly increasing number of dengue cases during the monsoon season. And I'd asked people that how would they prioritize their actions despite workforce shortages, limited resources, and increasing public pressure. So, what a good public health response does is it balances the epidemiological evidence and the operational feasibility, the resources which are available, and also it engages the community and the political realities. We'll have a look at what the cases were, and what was a problem statement. Because before doing anything, the first responsibility as a DHO would be to understand the outbreak. So, some key features that were given in the statement were we had a district A. The scenario was that there were 420 cases which were seen this year, with 115 cases in similar time frame. That's important, and 3 deaths, and also the total population which was given was 1.8 million. A few more features were given, such as the urban, percentage, which was 55%. And the key questions here, which were asked or which we are supposed to know, are that is this truly an outbreak or is it just a seasonal variation? And what are those areas or geographical hotspots that are contributing most to these cases? And are severe dengue cases increasing, or what is a trend which we see over time? And which population groups would be most affected? So that is given here that, what was the data that was shared was that a district surveillance unit was set up. We were doing line listing of cases. We are doing ward-wise distribution. Hospital admission trends were noticed. So as you can see, the trends were increasing week-wise. It's actually not 12, 18, but the number is shifted down, but it's like 120, 180, 280. You see a rising trend of cases. You see hospital admission trends. You note down the mortality reports, you see the entomological indicators. And in Indian context, what happens is many districts in such a scenario, they will start fogging, because that's the only response which is visible. And when there is media pressure, I understand that that's the option that sounds the best, and it sounds politically appealing also. However, evidence suggests that only fogging was never sufficient for sustained vector control for any of these vector-borne diseases. There were a few more things that were mentioned, that the monsoon season had just begun then, and the schools reported a lot of absenteeism, and social media was amplifying the public concern. And so, what would be the immediate response, or within 48 hours, what would be the response as a district health officer? Would be there are 4 priorities. I would like to cover this answer into, or this discussion rather, into 4 priorities, and I would definitely wish that people seeing this video would comment or correct me if I'm if my sequence is not right, or if there's something I'm missing out here. Okay, so first, of course, we would strengthen our surveillance. We would require daily reporting from public and private hospitals. We would identify hotspots, like I said, and we would demand some district-wise situation reports, trends in districts where it is rising. And because without surveillance, just blindly giving out resources is not effective target. So second priority here would be clinical management, improving it, because there should be treatment guidelines and protocols that should be distributed so as to not have confusion as to how to manage these cases. We definitely have to look for the side where we are ensuring that as a district health officer, definitely availability of IV fluids, platelets, or the medicines or the whatnot, like all that is adequately available to deal with these cases. Just sending out guidelines and not having drugs to deal with the severe dengue cases is really it doesn't make a difference. And then, of course, conducting death review meetings, conducting clinical briefings, because mortality reduction will depend on the timely treatment more than the vector control. And so third priority then next would be we have targeted vector control. where we would do source reductions in hotspot areas with larval surveys, and community cleanup drives are something that can be started. And of course, because eliminating breeding sites, is more sustainable than just putting out fogging. And the fourth priority here would be risk communication, where we would be doing, information education communication. We would be doing it in the local languages, and social media can be used. The same social media which was amplifying and putting the public pressure can be used to send out the activities done during this time. And the community behavior can be influenced significantly. It can act as a weapon against mosquito breeding. So, giving out dry days, or telling the people how to not have water filled containers or scrap materials, or clearing that out, declaring a dry day in those, in separate areas or geographical hotspots. And of course, fogging, yes, sure, but only in those areas where it's epidemiologically feasible, which are the hotspots, where doing that would actually bring out a, a, a good reduce in the number. And I would also like to discuss some of the, like, the SWOT behind this, because we do have a national program that deals with uh, any of the scenario which we're discussing about, which is the NBBDCP. And so that infrastructure is already existing, and so surveillance and all wouldn't require an extra training. There is a system that is already in place, and training the ASHA and ANM workforce is under that system, which is a strength of this uh, program. And the surveillance mechanisms are already established. There would be a dashboard. So, and community awareness of dengue and IC distribution is already a part of that. So we have a good strength for this. Some weaknesses, or rather constraints over here, would be the vector control staff shortage, which was mentioned. And yes, delayed reporting from the private sector is also one of the weaknesses here. Monsoons beginning, political pressure, and the 48-hour deadline definitely adds on to the weaknesses. Some opportunities that can be seen here would be the community participation that can be influenced. School-based interventions can be done, because there was a mention of how school absence were increasing, and so digital surveillance tools can be utilized. You can involve the local self-government, which is as equal to as a community participation that can be done. Some threats would be heavy monsoons, rapid urbanization, misinformation due to the social media amplification, and political pressure is something that is a threat to this. So, some high priority areas which can be done first is surveillance, clinical preparedness, and source reduction activities. Those are the main three focus areas. Less focus can be given to district-wide fogging. That would really utilize the already resource-constrained staff, this vector control staff shortage which we have. So we can give low priority to the district-wide, in a bigger geographical area, but we can, of course, do it in the targeted fogging in specific hotspots. So that can be done. So, how do you tackle this? To summarize this, in many districts, media pressure, political pressure would demand some immediate action, something that is visible. And so the administration, people will expect you to do fogging, or, but what we need to understand is how that just adds on to your resource constraint, and a skilled public health administrator would balance it with, you know, evidence based. So IBM is an important. Integrated vector management is something that needs to be practical based, and 2-3 source reduction methods, larval source reduction methods can be used along with fogging, but at limited the areas which are actually which are hotspots here. And so long-term prevention plan here, so that such outbreaks are easier to catch, would be strengthening your existing IHIP surveillance and your IDSP monitoring, also entomological monitoring, like vector control, and training the staff on the same. And even in community, having these school-based awareness programs, taking into, because such a large urban population, so resident welfare societies can be engaged. Some dry day campaigns can be done for them. And for the environmental measures, we could have waste management, scraps, and everything where those areas that are the breeding pools can be uh, eliminated. And so, urban planning can be also taken into consideration. And what all will be the indicators of success in short term would be that reduction in the weekly cases and reduction in hospital admission, that is, a severe dengue cases, and also reduction in deaths or mortality. And improved surveillance reporting with household source reduction is something that can be done. And long term, of course, we would want sustainable community participation in tackling such kind of outbreaks. So, public health decisions like these would involve a lot of evidence-based medicine, a lot of administration, handling the media, the politics, the community, answering them, and doing this within a span of 48 to 72 hours is something that needs to be learned, and it can't be taught only in the textbooks. And so, instead of like what are listing out all the interventions that we've learned, we can just ask that, given my population, given my resources, given my constraints, what combination of these interventions will have a greatest impact? And so this is how uh, we would tackle this. I would like to thank Firdaus for the comment on LinkedIn. So this is how she has tried to understand the scenario and given her comments. And so yeah, I agree with her. And this is exactly the kind of system thinking that separates, a reactive response from a calm, composed, and a managed one. And the 20% workforce gap is not a temporary problem. You can't just hire people and it's practical. It's there. It will continue to exist, and it's a reality that made her take the decision where she actually instead of focusing on the workforce gap, she instead drove the community. She's mentioned that will multiply without the payroll burden on the context. This is local ownership. This is what we talk about, the dry day campaigns, or we need to involve the local political people or religious leaders or anyone who has who can do that in the community. And secondly, she mentioned that they strategic risk communication as a narrative where it's the advisories are issued, but they don't really shape what is happening. Um, you know, it's like you have to change the narrative here, and you cannot just do what is politically right, but you need to understand that it should have a long term impact. Third, she mentioned about clinical triage and death audit. Definitely, the rumors need to be settled. The social media needs to be utilized where the facts can be established, activities can be listed down, and where so she's really covered all the points, and this is exactly what needs to be done. And so I'm glad that someone has replied with a great alternative or parallel actually. And yeah, I this is some of the one of the firsts I'm trying to cover here. Maybe you can mention in the comments what else can be covered, what uh, we can continue the series. I can post another clinical scenario next time, and or else if you have some suggestions, do suggest me on what all we can do, and I'll try to bring that into picture. And I would love to have a discussion next time if someone's ready for that kind of brainstorming. So thank you so much. Thank you all for listening.